So I'm going to talk about today to talk about depression in the digital age. Thank you, Shri, for inviting me to this particular lecture, and thank you, Dinushi, as well as Niroda, for the kind introduction. And so, uh, this is all about depression. I think this is a little bit of myself, and already Niruda mentioned about this stuff. So I will skip this slide. And uh, first of all, I just want to play like 4 5 minutes a video.
Depression is the leading cause of disability in the world. In the United States, close to 10% of adults struggle with depression. But because it's a mental illness, it can be a lot harder to understand than, say, high cholesterol. One major source of confusion is the difference between having depression and just feeling depressed. Almost everyone feels down from time to time. Getting a bad grade, losing a job, having an argument, even a rainy day can bring on feelings of sadness. Sometimes there's no trigger at all. It just pops up out of the blue. Then circumstances change, and those sad feelings disappear. Clinical depression is different. It's a medical disorder, and it won't go away just because you want it to. It lingers for at least 2 consecutive weeks and significantly interferes with one's ability to work, play, or love. Depression can have a lot of different symptoms: a low mood, loss of interest in things you'd normally enjoy, changes in appetite, feeling worthless or excessively guilty, sleeping either too much or too little, poor concentration, restlessness or slowness, loss of energy, or recurrent thoughts of suicide. If you have at least 5 of those symptoms, according to psychiatric guidelines, you qualify for a diagnosis of depression. And it's not just behavioral symptoms. Depression has physical manifestations inside the brain. First of all, there are changes that could be seen with the naked eye and X-ray vision. These include smaller frontal lobes and hippocampal volumes. On a more micro scale, depression is associated with a few things: the abnormal transmission or depletion of certain neurotransmitters, especially serotonin, norepinephrine, and dopamine, blunted circadian rhythms, or specific changes in the REM and slow wave parts of your sleep cycle, and hormone abnormalities, such as high cortisol and deregulation of thyroid hormones. But neuroscientists still don't have a complete picture of what causes depression. It seems to have to do with a complex interaction between genes and environment, but we don't have a diagnostic tool that can accurately predict where or when it will show up. And because depression's symptoms are intangible, it's hard to know who might look fine but is actually struggling. According to the National Institute of Mental Health, it takes the average person suffering with a mental illness over 10 years to ask for help. But there are very effective treatments. Medications and therapy complement each other to boost brain chemicals. In extreme cases, electroconvulsive therapy, which is like a controlled seizure in the patient's brain, is also very helpful. Other promising treatments, like transcranial magnetic stimulation, are being investigated too. So if you know someone struggling with depression, encourage them, gently, to seek out some of these options. You might even offer to help with specific tasks, like looking up therapists in the area or making a list of questions to ask a doctor. To someone with depression, these first steps can seem insurmountable. If they feel guilty or ashamed, point out that depression is a medical condition, just like asthma or diabetes. It's not a weakness or a personality trait, and they shouldn't expect themselves to just get over it, any more than they could will themselves to get over a broken arm. If you haven't experienced depression yourself, avoid comparing it to times you've felt down. Comparing what they're experiencing to normal temporary feelings of sadness can make them feel guilty for struggling. Even just talking about depression openly can help. For example, research shows that asking someone about suicidal thoughts actually reduces their suicide risk. Open conversations about mental illness help erode stigma and make it easier for people to ask for help. And the more patients seek treatment, the more scientists will learn about depression, and the better the treatments will get.
Right, I'm going to start the lecture. And before this, I think you have all seen this short video. And I don't think like you would learn anything new, because as doctors, you all know, you know like what is depression, what are the basic treatment, and I don't want to teach you again about this. So this particular lecture is not all about the depression clinical features and the basic medication and other therapies. This all about, as the topic correctly mentioned, it's all about a different way of seeing depression in the modern era. So you will see that when the lecture progress, the discussion progress. And start with the definition. You could see the major depressive disorder according to DSM-5, and then even ICD-10-11 is more or less similar to this definition. It is a serious psychiatric illness marked by persistent low mood, anhedonia, and other cognitive, behavioral, and physical symptoms. Diagnosis require more than five symptoms. This is according to DSM-5, and with bit different to ICD. And it should last for 2 weeks, with at least one being low mood or loss of interest. Right. Okay. So about depression, relevance of depression in today's society, it is rising. The rates are rising globally. That is one main important that as doctors we need to know about depression, and especially among youth. That's something we need to talk about, and we are going to talk about in this discussion. And some of the contributing factors are social media, economic strain, and isolation. You would see this isolation, which is very important word, and we all know, and you might surprised to hear or see this isolation. Now the world is on your palm. Everybody is connected to each other. So how could this be isolation? And how could this be isolated from others? And you will learn in the next few slides what I mean about this isolation. Of course, we all know about COVID-19 impact, the burnout, school abstinence, and the growing awareness and reduced stigma. That's again a positive part of the depression, because the awareness, especially with this, the social media and other technology, improvement of the technology, so the awareness is growing, as well as it actually counteract with the stigma. Right. What are the causes of depression? These are not the whole list of causes. And this, again, I'm talking about in modern society. Social isolation and over reliance on technology. So I would like to talk a little bit more about this particular thing. As I told you in the previous slide, what do you mean by isolation, right? And not like in 2, 3 decades ago. Now, everybody is with a screen, like either a mobile phone, laptop, a palm top, or whatever, the tablet, or even sometimes uh, TV. So this isolation means now we all interact with, especially the youth, interact with our own technology, whatever the screen you have. And so we little by little cut down our human connection. So that does mean isolation. So you're isolated with your own technology, with your own stuff. So that is why we mean isolation. And the over reliance of technology means the same, that because of that this technology, you are more isolated from other parts of the world. I mean this in a simple way. When you go to a hotel, a restaurant, or in a public transport, or sometimes in a queue in a bank, you could see the market significant difference. Most of the people are seeing on their mobile phone or whatever the screen, and rather than talk to each other, or just visualizing other stuff. It's all about putting on your eyes on the screen. So that is why we see some of the tragedy happen, because you are totally cut down from the outer world. And other causes of depression, like financial pressure, we all know about it, job insecurity, environmental uncertainty. This is not only the climate, there are so many environmental uncertainty around us, and disrupt sleep patterns and sedentary lifestyle. Again, this word is very important. Sedentary lifestyle, again, it is linked with this reliance on technology. We don't move because everything is on the screen. We can do anything on our screen by just clicking a single click, just clicking a single tab. So this is our global and the regional comparison, and probably you all know about this stuff. The global average is about 3.4%. In that was in 2019 WHO estimate, but now it has increased up to 5%, around 5%. That this is about depression. And in Europe, mainly higher rates can see in Greece and Portugal. That's about 7.6 and 7.1. In South Asia, India's rate is around 4.5. Mind you, this 4.5 is could not be the exact value because there are a lot of underreporting. And Oceania, like Australia, is around again 5. I mean, tally with the world rates. And North America, US has a rate of 6.5 with their population is nearly 19 million. So it's all about 5% in the global, globally in all around the world. And when it comes to the numbers, it's about 280 to 300 million people suffering from depression at this particular moment. And Africa and Middle East again is around 7.5, and Sri Lanka, you could see the higher rates, especially in youth, that could be due to the post-conflict stresses, economic hardships, limited mental health infrastructure, and etc. So many reasons I'm not going to talk about. So in Sri Lanka, it's 19.4. Of course, it is very high value. And I know that some of the figures, the WHO figures, very less than this value. But this actually was a recent meta-analysis, prevalence and associated factors of depression in Sri Lanka, done by group of doctors in Sri Lanka, group of experts. It is a systematic review and meta-analysis which shows, including over 52,000 individuals. This shows it's 19 point, it's like one-fifth of the society. So among young people, the rate was significantly higher. It's nearly 40%. You could see the relevance of depression and relevance of this topic nowadays. And other subgroups like adults, it's 8.7. Older adults is 18. The older adults 18 is more or less similar to other parts of the world, because they are a group, a specific group that they can have the tendency of having depression. And the maternal population, again important, it's 16.9. So it's high. In 2017, government reports showed that 30.4% of newly diagnosed mental health cases were depressive disorders, which means uh, out of 100 of newly diagnosed mental illnesses, it's one third of the people are diagnosed with depression. Again, it's tally with the global rates. Right. Another one, you could see the Sri Lanka 19.4 and compared to the some of the other countries. But keep in mind these differences in screening, sensitivity of diagnostic tools, and reporting culture influence that can vary the numbers. So Sri Lanka's high prevalence may also reflect the better recent data collection. Some of the countries actually, I must tell you that I assume that some of the countries in Asia could be much higher rates than in Sri Lanka, but they don't have enough sensitive researchers as well as sensitive tools to show the exact values. What are the cultural and social factors affect to depression like? Its mental health stigma persists in various cultures across the whole world. This stigma is there. And social media's dual role. We know that social media, that's a debate every day. You can see in most of the media, like whether disadvantages or the advantages overweight this social media's role. And the awareness versus pressure. Of course, yes, the advantage of social media is it gives us a lot of awareness about depression, and the reach out to the facilities that you can have the treatment, as well the pressure. So we have to balance both, whether the advantages or disadvantages actually overweigh this in social media role. And urbanization, of course, we know the increase in population and then urbanization, community erosion, and again, I'm talking about this isolation. Impact on daily life. This is not the whole, but they decrease work productivity, which immensely affect to the society, economy, and etc. So to everything in the society, and then the presentism. So when people get depressed, they don't move out, they don't go out, they don't meet people, they don't go for work, and strain interpersonal relationships, which is again talk about, the link with the technology. And somatic complaints, you could see the fatigue, appetite changes, sleep disturbances, and so many things we can talk about in the next few slides. Right. When you talk about depression, we can't just avoid suicide. You could see in suicide rates in Sri Lanka. In 1995, it's 47 people per 100,000. And it was very high. I think we were in 1995, we were in the top or the second in the world with regards to the higher rates of suicides. Because of this time that there was a presidential task force appointed by the government, and they identified to some of the reasons for this completing suicide. So the rates declined in 2000 because of their recommendation. Few of their recommendations, one was to pesticide regulations. So because of that, the rates start declining in 2000. And 2020, it was 14.2 compared to 47 in 1995, which was a huge improvement, huge significant improvement. And in 2021, it's 14.74, right? The slight increase. And now the most recent 2024 is approximately 16.3. And I'm pretty sure, and I don't want to see that being a doctor and being a psychiatrist in Sri Lanka, but I'm pretty sure that this will start increasing if you don't do enough interventions in future years. Right. Suicide is preventable. When we talk about depression, again, we need to know about more about suicide because this is the end result and this is the significant impact of depression. It is preventable. And there are a lot of myths and facts about depression and mostly about suicides. Let's see a few of them. The myth is talking about suicide makes someone more likely to do it. But actually, it is not. The fact is, bringing it up shows your care. Honest conversation can actually reduce the risk. People think talking about the suicide, a patient with a suicidal feeling, can make them feel more suicidal. No, actually, please talk to them. You won't be a professional. Sometimes could be your friend, a family member, a person in the society. Please talk to them. That significantly reduces the risk of committing suicide. The myth is the second myth, they're just doing it for attention. Every cry for help matters. I mean, it's like most of us, even the medical people, they think like, okay, this is for drawing attention. They just mention, I'm going to suicide. No, actually, when they say that they have feeling or plans or thoughts about suicide, it is you have to take it into consideration. Take it seriously. Most people who die by suicide have signaled their pain beforehand. There are more researchers on this that they have found 90% of, like 9 out of 10 people, 90% of the people who committed suicide actually mention their suicidal plans or suicidal thoughts to a health professional. So so we missed it, unfortunately. We missed it. Only the myth is only people with mental illness die by suicide. No, it's not only the mental illness causing suicides. While a mental illness is a risk factor among all the mental illness, depression is the highest risk factor for suicide. But anyone facing extreme stresses, trauma, or loss can be vulnerable. And I, I could say that you all know in the media and in your the profession that we see every day, especially younger people, they just commit suicide only because of a message from their girlfriend, only because of simple thing. So that's something we have to take into the consideration. Another myth, if someone really wants to die, nothing can stop them. So that's another myth. Even I have seen some of the health professionals have, talk like this. Suicidal crises are often temporary. The connection, support, and safety planning can save their lives. Mind you, this is we talking about a life. Right. Another myth. People who attempt suicide are selfish or weak. No, actually, suicide is rooted in deep suffering. Compassion, non-judgment is the path to healing. And another myth, suicide is not preventable. As I told you in the previous slide, the first slide, with early intervention, treatment, and community support, suicide can be prevented. Why we talk about this suicide? We know the depression, if we do not treat, number of people can end with this disaster. Right. So suicide prevention for clinicians. What are the actions as doctors you could do? I mean, you don't have to be a psychiatrist. You don't have to be a mental health trained professional. The GPs are the first contact of most of the people. I mean, GP in the sense like when I say GP, it's like the doctors who works in other wards other than the mental health units, right? Especially recognize risk factors and warning signs of depression and then suicide. The recent losses or traumatic events could be a high risk factor. Chronic pain, debilitating illnesses like chronic illnesses going on for years and years. Substance use is one of the leading cause. And someone is expression of hopelessness or withdrawal from the society, withdrawal from their friends, their families. And you need to create a safe and non-judgmental space. Say, for example, like most of the people are, I mean, by our naturally, by our nature, that we tend to be judgment. But you need to know, please do not judge people. I mean, so that's something like they will have a good therapeutic relationship when they feel like you are a non-judgmental person. So your presence is always matters. Please do listen to them, right? And building trust opens the doors for the patient to disclose their problem. Number three, screen early and often. So there are a lot of screening tools. I mean, you don't have to use these screening tools. You can start treat them or you can refer them and collaborate on a safety planning. Medication is not the only thing. Sometimes they just have vague contracts. Okay, so please don't do this. If there's anything, come back to me. That doesn't work. You have to create a very practical and intense safety planning when you are dealing with person with suicidal feelings. And refer and always follow. So the depression treatment option, just touching this, there are some therapies, like not all I mentioned here: cognitive behavioral therapy, interpersonal therapy, psychodynamic therapy. There are a lot of therapies that we could do in depression. Medications, of course, we all know. I mean, I know very little more than you because you know everything about these usual medications like SSRIs, like fluoxetine, escitalopram, sertraline are the most common things that we use in Sri Lanka. SNRIs like venlafaxine, and some atypicals like bupropion and mirtazapine. Tricyclic antidepressants and monoamine oxidase inhibitors are nowadays we don't see much. It's very rare because it is reserved due to side effect profile. And the novel agents, sketamine, brexanolone, and ability, like there are some medications, but I think I have not used these things in Sri Lanka. And the ECT, we all know, number one option for depression, severe depression mainly, and depression with psychosis. There are some emerging approaches. Again, we don't see much in Sri Lanka. Psychedelic assisted therapy, digital mental health platforms. Of course, we see some of these support mental health platforms in digital media. And vagus nerve stimulation, I don't think that we do in Sri Lanka. And personalized TMS, again, I'm not aware of that we use TMS, that which means transcranial magnetic stimulation. We do use in Australia, Europe, and then USA and other countries, but not in Sri Lanka yet, according to my knowledge. Prevention and awareness, early screening, and especially school-based intervention. Why I focus about this school? Because we all know now the emerging high rates of youth depression is one main problem in our society in Sri Lanka. Mental health education campaigns very important, and strengthening access to care and community support, because sometimes people, we do provide the care, but they don't come, not because of stigma, because of unawareness. So we have to strengthen the bonds between the care providers and the people who actually need. Right, presentation to GP or hospital and another specialty, other wards is different than we think. It's always obvious that we all know about depression, like okay, low mood, lack of energy, they are crying, they are not coming out from the room, stay in the dark. Those are symptoms and the signs that we all know. But now the presentations are more atypical, so that is why we need to be alert. One is irritability. In Sri Lankan society, I have seen, so some of the depressive features are not actually we see on them, but they have irritability. When we dig into that and then we see these people with irritability is ultimately ended up with the diagnosis of depression, and when we treat them with depression, their irritability goes down. So irritability is one rather than sadness that you all know linked to depression. Irritability is one thing that you need to think about. Okay, this could be a depression. And somatic complaints like headaches, stomach, especially in younger age, school age people, fatigue, and are common somatic complaints. Sleep disturbances, of course, we all know it's not only insomnia, sometimes excessive sleeping also could be a feature of depression. Changes in appetite or weight, we all know about this, and some functional impairments. Especially, I must tell you, I mean, you are listening to this as your CPD lectures, but apart from our role as healthcare professionals, as doctors, most of us are parents. You do have children in your life. So you are mothers and fathers, and we have to play dual role. So in your children, dropping school performance or disengagement from studies and school refusal is manifestation of depression. Social withdrawal from friends and family, loss of interest, again, these are features of depression. Emotional and cognitive signs, low self-esteem, difficulty in concentrating or making decisions. Some people are very indecisive, not by their nature. Sometimes all of a sudden they say, Doctor, I can't take a decision now. I'm a bit weak. I always ask from others, my loved ones. So which could be a feature of depression. And pessimism, of course, we know the pessimism is part of depression. Some of the risk behaviors, self-harm behaviors. So recently, I have seen a little girl. I mean, I was shocked to see that, and she had self-harm behaviors. Mind you, like she's only 11 years, 10, 11 years, and she had a serious self-harm, cut injuries to her forearm, and that's with not with the suicidal ideation, but with kind of a the maladaptive coping with the stress. So we see like this is not the Sri Lankan society and the depression that I saw a few years ago. And the substance use, of course, significant problem, increase to a very high level, and some online behaviors like digital withdrawal, exposure to harmful content, part of depression, and the barriers to disclosure because of the stigma, they don't come up and they don't recognize their symptoms as depression. That's why I told you like these slides you can see. So some of these presentations are very straightforward, but some of these are not that clear. And you always have to have the curiosity whether this could be depression or something else. And so they may present for unrelated issues. Say, for example, like a couple recently married, recently came to my practice, and they just wanted to get divorced. And soon after the marriage, like only few months, because of the irritability of the wife. And then ultimately, I diagnosed that female partner as depression, and then treated her. So that's something to prevent their divorce. So we think like the presentation is different. Sometimes they come with a different reason. Sometimes they ended up in the surgical wards, orthopedic wards, but ultimately dig into that the problem, the root cause is depression. A GP is, I mean, when I say GP, it's not only your GP practice, it's about all the other specialties, other wards, apart from the psych ward. GPs are often the first point of contact and are a unique position to detect early signs. Right. How do you care a child? I mean, child in the sense like when I say child, it's again you can see youth, the younger generation. How can you take care of child with depression? First, be present and listen. That is the one that we lack in our society. I mean, you could think about yourself. Do you present and listen to your children? So ask from your patients and their caregivers, their parents, do they give enough time, enough space for their children? And just to listen at least, not to do anything, because we know that I'm not blaming, because the high functioning society, and it's like a mad race that we always run through. So because of that, we don't have enough time to put attention or at least to listen to our children. So that is one reason. Always when you take care of a child, you always to be listen and be present for them, and create a safe environment in at home. Let's keep routines for meals, routine sleep, and downtime. Most of the children, younger children, you think about your children at home, they don't have routine meal time, routine sleep time. It's all over the places. Encourage healthy habits. like exercises, balanced meals, and limited screen time. So we have to talk about this screen time in a totally different lecture, like, because it can take hours and hours to talk about this screen time and how do you calculate. People ask whether we should cut down it to zero or whether we let them to do as their wish, because nowadays that the technology is like even the schools, they just, especially after COVID, they just mention things, sending messages, sending homework using technology. So whether we can cut it down to zero. No, it's, you can't say like zero. If someone asks, zero screening time is something like you cannot, I mean, it's good if you can, but it's practically very hard. So you have to have a screen time calculation. That's a different thing that I talk about later if I get a chance in another day. So calculate your, the child's screen time with him, and then you could see like, okay, what percentage of time that you stay with screen. And sometimes when I have patients, especially the younger people come with screen addiction, I do calculate their time with them, not with the parents, and then they, most of them, that they realize by themselves, oh, this is too much. So that is how we need to deal with these people, not to go down to zero. Not, you can't, I mean, it is good, but if you can, no. Watch for warning signs. There are mood shifts, sleep changes, or talk of self-harm behaviors, talk about self-harming. So that's something alarming signs. And avoid toxic positivity, like say, that sounds really hard. So care for yourself too when you have like, when you dealing with the depressed people, depressed patient, or at home you have a someone like your family member with depression. It's definitely you need to take care of yourself. Your mental health should be in a optimum position to take care of others' mental health problems. Some of the clinical scenarios. Okay, I'll start with the interesting one. I mean, those interesting, like it's a disaster. I could say I got a 21 year, like months ago, I got a 21-year university student. He was in year two, yeah, year two. And till that point, he had been worked really well, studied well with top marks, and he felt depressed and suicidal after relationship breakdown, which is very common. The relationship breakdown, the girlfriend or the boyfriend, left you, and then you feel like grief, and then sometimes some people go into depression. It's not very uncommon though, but so he has stopped his studies, and he used to stay in a dark room and didn't eat at all and did not answer to his friends, did not want to meet someone. Somehow he ended up in my room and talk about his girlfriend, and he was crying all over the interview. Like he said, like he still remembered they went out for coffees, went to beach, and all the things that they talk about. So then later I found that's, mind you, like I spent a good half an hour to realize that this girlfriend, what he talked about, was an AI generated girlfriend. It's not a real girlfriend. And can you believe that? I was not, I mean, I didn't say I was shocked, but was surprised to see. And this is Sri Lankan youth. So they don't need any girlfriends now because they can find a girlfriend with a chatbot. So this particular 21-year-old student actually had a relationship for more than like 3 to 4 months. He played a game, and the gift that he had by becoming the top scorer of this game is a very beautiful AI created girlfriend. Actually, he showed me the the photo on his phone, and I couldn't realize this is AI generated. Right. Then, just to show you, right, before that, this is one of the dark side of AI girlfriends. This actually I obtained this from YouTube. You can see a chatbot at center of teen suicide. So this is news is from Florida, USA. A teen boy had a relationship with AI girlfriend, and she has left. Thereafter, he unfortunately committed suicide because his girlfriend, the AI girlfriend, the virtual girlfriend, left himself. And now parents are starting. Uh, filed a court case and then try to sue the software company. I don't know what would be the decision, but do you think like this is only in USA? And what would happen if this 21-year-old Sri Lankan university student, he did not seek help from mental health professionals? What could be the end? And maybe tomorrow or day after, if you hear this happen in Sri Lanka, it's not a surprise, unfortunately. So how is it to find a girlfriend? This is something I mean interesting. Okay. Then I wanted to just because I didn't actually do this, even though I hear many these kind of stories. Today morning before the lecture, I also wanted to know how easy it was. So I just found this picture in Google, and then I asked uh, chatbot just make a girl exactly like this. This is what chatbot gave to me. Right. You could see. Right. If you don't see this one at the first picture, if you see only this one, do you think like this is a virtual one? I don't think so. Right. And then we all know like people say oh girls are very nice when they are happy and smiling, but when they feel sad, when they get angry, it's not the same girl that we see. It's always better when you make, when you start a relationship, to see that when they feel sad or angry, how would they like be, and otherwise we go crazy. So I asked AI, just give me a picture when she's sad. This is, there she is, and need more love. Okay, this is the picture that gave it to me. And then just a one click away, I can make this girl talking. And after about 1 or 2 hours, if I feed my every interest to her, and she would be my best friend. And in a week time or maybe in days time, and he could be one of your girlfriend or my girlfriend. So I don't want to test myself. I stop from now. Okay. So AI girlfriend, it's growing up over 500% in 1 year. So you could see, I mean, especially the girls, especially the females, mind you, like it's very, very difficult now to find a male partner because they all have this AI girlfriend option. I'm just joking, right? But it's not a joke. It will happen. So there's a global surge in AI companionship from 2022 to 24, and searches for AI girlfriend rose by 2,400%. This is not simple. And the market size is about US dollars 2.8 billion in 2024, and they predict it could be 9.5 billion US dollars by 2028. Right. 1 in 5 men on dating apps have interact with AI girlfriend. 55% of users engage daily. I mean, engage daily with AI girlfriends, and not only girlfriends. It's the vice versa as well, boyfriends. The most engaged countries, of course, we can have breathe a bit of space because it's not listed. Our country is not listed yet. Singapore, Sweden, Finland, South Korea. Those are the more vulnerable countries. But who knows? The Sri Lanka will come to this list no sooner. Another case scenario. Those all are true case scenarios which I came across. A grade 9 school girl stopped schooling and assaulted her mother when asked to go to school. I mean, mind you, this is grade 9, just only 12, 13 years of age. She has assaulted badly her mom, and she was injured and had to, sutured. So it's not simple thing. This didn't happen. I'm not talking about, the new generation, they are bad things, but this is what we see. I mean, this is not their bad. I mean, you have to responsible as the more elderly generation. We did not take care of our younger generation better. So that is why we see this. I'm not blaming on them at all. So this girl actually had a very violent behavior. Then ultimately ended up with diagnosed depression. This is a one manifestation of depression, and then we treated her, and now she is getting better, and then she is settling. Another boy addicted to the screen 18 hours a day, skipping his meals, no proper sleep. And, this particular boy actually had a, 9 A's in his O levels. And then thereafter stopped schooling That was a common mistake most of the parents do. They because of that he obtained nine A's, nine distinction, I mean nine top grades. So they have bought a laptop for him, and then he started playing on a game, and then moving on to the laptop to the phone. So then thereafter, what has happened? He completely stopped talking to others. So this is how he ended up, and then he locked the gate one day. The parents were outside, so it happened in the other way around in our time. But what has happened then thereafter, the parents actually had to call the police to bring him to the hospital, bring him to the mental health facility. This again, he addicted to the screen and then ended up with depression. We treated him for depression with antidepressant and started therapy. Now the good thing is, like most of these children, actually, when they, uh, when they get treatment, when they get interventions, and when they get desired therapy, they tend to improve. So that's the good thing. Another teenage girl in Colombo with abdominal pain and unable to attend school. So this abdominal pain was investigated extensively. This is a very common problem in most of the children, not in the teenage, even the smaller kids like. So you see, this is abdominal pain is very specific, central abdominal pain. Sometimes they come up with a headache as well. So those are non-specific symptoms. Of course, you have to investigate. I'm not telling that stop investigation, but ultimately you could found nothing. So that's depression. A young girl left the house at midnight. This was a very recent patient that I saw at Mathura. This girl actually left her house from a good background, a good family background, left her house midnight, which is very uncommon for like the girls, like it's not safe, no proper reason. And it was irritable when the parents tried to stop her. So it was again, it was screen addiction with substance use. Mind you that this girl, school girl, used substances as well, and later became depressed. So the part of depression is that we see these behaviors, as I told you in previous slide, some of the atypical presentation. She all of a sudden she wanted to give up everything. She just left the house and then ended up in our care. So she's doing well now, which is good that because the depression, if we see the psychiatrists, mental health professionals, counselors, psychology, if we see these cases like these patients, we actually could treat them. So that's a good part of depression. Right. The take home message: in modern medicine, recognizing depression isn't just a psychiatric responsibility. I'm not telling that we are not responsible. Yes, we do. But it's a clinical imperative. Behind every unexplained symptom, missed appointment, or quiet, I am fine. Sometimes they say, I'm fine. Please don't disturb me. I'm fine. But that is not fine. It may be a patient silently battling despair. And as doctors, your empathy, presence, and proactive attention can eliminate what patients often struggle to say. Depression is treatable, but silence is not. Thank you for everybody listening to me. And because we had lost 10, 15 minutes from the beginning again, and the technology was not fair with me. So anyway, that's how technology is. So I stopped from now, but I'm happy to answer any of your questions from now onwards. Are there any questions we have, Niroda?
Sir, we have questions they have sent from earlier. Like I will just say some of
Okay.
the things. Uh,
Yeah, sure.
yes. The first one is explain how to get rid of digital addictions. I will
Again,
say.
it's good. Yeah. Okay. So I think I just touched a bit, but it's like this. Digital addiction is a common problem now, especially in the youth, but it's not only, in the youth, like even sometimes we see the professionals, even the mental health professionals, they have this addiction. So it's across the whole age group. And we need to first to have a proper conversation with the person. I'll get an example of a child. So you need to talk to the child, and then just to have a proper calculation of a screen time within a 24 hours that we say, in a simple example, 24 hours, I usually sit down with the child and they say, okay, we'll cut off 8 hours for sleep and the remaining 16 hours, we cut off another 6 hours for like, schooling and other stuff. And then it reduced up to 10. So cut off another 4 hours for other stuff like, the transport time and then your playtime or whatever, and without the screen. So ultimately, we in a 24-hour day, we have a child with 6 hours of leisure time without having anything. In these 6 hours, before this calculation, I usually used to ask the time that you spend in a screen. They say like 3 hours. They think like out of 24 hours, 3 hours is not that bad. But after deducting all these things, then we have 6 hours with this child, that the leisure time, and then out of these 6 hours, now 3 hours they use to watch screens and play with screen. So 3 hours out of six means 50%. That is too much. So when I calculate this, as I told you in the lecture, most of these children, they realize by themselves saying, oh, this is too much. So otherwise, we tell them. So calculate the screen time, sit with the child, calculate the screen time, and then make them self-aware. So that is number one strategy. And if not, sometimes because of the top level addiction, sometimes we have to remove the screen. And if we do, it will take about good 3 to 4 weeks them to come out from the withdrawal. It's you. Do you know like heroin addiction and other substance addiction. And when we see the brain images of screen addiction, there are more or less similarities in this screen addiction. So it's a huge problem.
Yes, thank you, sir. And there's another
Yeah.
question like, what is the cause of virtual autism? Like similar things, maybe.
You mean the virtual autism? So when you say autism, it's like we don't say this particular reason for autism. There are so many reasons. When you say autism, it's like ASD, autistic spectrum disorder. So we take it as a whole spectrum. So the diagnosis of ASD is something. There are some causes we can see, the genetic or like the pre-birth causes like, but in the virtual autism, of course, it's like this. The autistic spectrum disorder, the main issue is like poor communication, not communicating at all, right? So in virtual autism also, it's like the person is addicted to screen, addicted to this technology. They just cut off, as I told you in the lecture, they just cut off all the human connections, which is more similar to ASD, right? So the communication problem and then isolation and cut down all the human connections is, you see, those are the things in ASD. And then the virtual autism also the same scenario we could see in the suffered people.
Yes, thank you, sir. And there's like another question. Is there any mental rehabilitation centers around Sri Lanka? And
You mean there are rehabilitation centers? Not much though. There are rehabilitation centers, as I know, for drug and alcohol. I mean, mainly drug rehabilitation, but not a lot. But I'm not sure any other rehabilitation centers. There are few in some part of Sri Lanka, but I don't think it is enough. And it's not something enough for this whole crowd. They need this rehabilitation. And I'm telling you, some of us think that some people, they do need rehabilitation. Actually not. When we talk about substances, it's about only 15 to 20% of our max of 20% of the people, say like 1 in 5 people with substance abuse need rehabilitation. All the other people, we can actually create a safer community and treat in the community. They don't need to have a residential rehabilitation facility. But I do believe, with my experience and with my little knowledge, I think Sri Lanka, what need at the moment is like more community based rehabilitation, like day centers. They don't have to come and stay like residential day centers, and more community based rehabilitation, which we can actually practically do, especially countries like us. with a, economical problem, rather than try to find a, the residential rehabilitation. And even in Australia, where I work frequently, we don't see enough residential rehabilitation centers. No, I don't think like in other countries. I have not worked with, but I know. I don't think like enough rehabilitation centers in even in developed countries. It should be a more strategy towards community rehabilitation that we have to focus on.
Thank you, sir. So there's another thing like what is the accepted screen time for adults? Like, I mean,
Okay, it's a very good question.
yes.
Right. Um, I would rather say with children, again, you can calculate your screen time. Again, I'm telling the same example. This is a very important, I mean, same scenario. You just take 24 hours a day, cut down your sleep time and cut down your all your work time, and then, reduce all the other, like the transport time, your other time, like meal time, everything. And then you will see, okay, the rest of the leisure time you have 5 hours mostly. I mean, maybe less than that for the adults. So 5 hours, and then you before everything you calculate your screen time. Then you could compare. I'm on the screen for 2.5 hours. Now I have 5 hours left after all my work. So it's again 50%. That is not totally acceptable. So I would rather say 10% is better even for children as well as adults. But for children, when I say 10%, the content should be monitored by adults. So for adult, the question, adults, I would rather say 10 or maximum 15%. But that does not mean the people who work in the screen. Say, for example, like this is this lecture that I have to do and on the screen, so that I do not calculate. The working, some people are working from home, so you can cut off the screen time. I'm just talking about the screen time that you in the social media or other stuff.
Okay, thank you, sir. So there's like some practical problem like measures that can be taken to reduce depression among doctors in general.
Exactly. I think that's something really we need to talk about. I'm not quite sure because I worked closely with Sri, but not recently because I was not available in Sri Lanka those days. So I think Sri may have, or else Sri can look into this. The depression rate among doctors. I know that people have done stress levels among doctors, healthcare professionals, but actual depression rate in our doctors population, we need to definitely look into that and have a proper research data and the intervention. Of course, we have some countries, like in some Europe countries, developed countries, they do have a program for doctors only. So we have to, create a program, a mental health support program for the doctors, and then they can call, or they can. I know that we have seen like tragedies happen to the doctors, like the suicides and other stuff, giving up jobs, and there are a lot of hidden. And as I told you, like in this lecture, there's a hidden epidemic. So these hidden problems, they are family problems. I've seen every day doctors coming. So we need to have a proper employment support program for the doctors. And that's something like providing counseling, providing psychological supports, and providing treatment. So that I know there are a lot of people willing to do this. I'm also happy to, contribute it if someone can take the lead and make it possible.
Yes, thank you so much. So there is like regarding the treatment, there are like few questions I will get together all of them and ask you. So they asked like what are the indications and when are we going to start the drugs for depression? And another one is can we give alprazolam boards or OPD setup as an MO if we see symptoms without a consultant psychiatrist opinion? And there's another one like how to address side effects of medications in personalized matter, like post depression.
Okay, I would tell you like this is something I wanted to bring up in my lecture, but because of the uh, you know time constraint and the stuff, I didn't touch on those stuff. First thing, I'm telling you a message. Please do treat depression. Please do not wait until these patients seen by a psychiatrist. Right?
Yes.
I don't know how practical this is. You need to have a better knowledge. I do believe with MBBS you can diagnose, the knowledge of MBBS and the other, all the, the knowledge that you gain from these kind of lectures and other materials. So you are confident to treat for depression, because it's not something that, if you can, mind you, like 30% of these, I mean, the very high rate of prevalence of depression, and 30% of all mental illnesses are depressed people. So it's like one third of all mental illnesses attributed by depression. So you need to treat them. Say, start, just get a better knowledge about depression, and if you have any suspicious, just, screen it, and you can see that this patient is depressed, not only with this lecture. Like, you can have more knowledge on the on your web, or you can get more information, and then start treating with simple antidepressants. Say, for example, like the common antidepressant we use, like sertraline, starting with 25 milligrams and gradually weekly increase up to 75 or 100 milligrams. You don't have to have a psychiatrist. Starting with fluoxetine 20 milligrams, and then treat for depression for 3-4 weeks, and then see whether there's any improvement. Most of them, they would have improvement, and then later you can say, at complex cases, or if not, your treatment is not going to work, then you can filter them and then send to a psychiatrist. Otherwise, don't wait until these patients seen by psychiatrist. So start with fluoxetine, start with sertraline, or some other medication, like safer medication, citalopram. So keep one or two medication with you, and then get a bit of a knowledge and start treating them. If you really see this patient is depressed, it's very hard to diagnose depression. And I did not touch about the clinical features and the treatment options, because I was thinking about a different way of a discussion. But if we get a chance, we can talk about depression later. It is the leading cause of one of the leading cause for debilitation. So please do start treat them. And those medication like fluoxetine, sertraline are very safe. You can say, like, just not for children, but like just above the age of 10, you can freely start treating with fluoxetine, sertraline, and other common safer antidepressants. So that's number one thing. The common side effects, they can have some gastric irritations, nausea, vomiting. Some people have headache, and when you use at night time, most of antidepressant can cause insomnia. So that is why we prescribe it them in MANE doses, like in the morning, and just start with a smaller dose, and then see, if not, refer. But even though you think about a referral, it won't happen suddenly. You can't refer a patient right now and then seen by a psychiatrist tomorrow, because we know there's a lack of psychiatrists in Sri Lanka. So that's something really, demand is very high. So you can treat as a GP, and then maybe not in the GP setting, in the other wards also you can start, and then later refer to psychiatric services.
So thank you very much, sir, for the informative lecture, and it's a very practical, actually, the topic in these days. So our sincere thanks goes to Dr. Dhanuja Mahesh Kankanam Hevagita, consultant psychiatrist, Latrobe Health, Victoria, Australia, and for his excellent lecture and for their precious timing. So thank you so much, sir, again, and for your informative lecture.
Thank you, Sri, and thank you. Sorry for the technology issues, and thank you, Sri, and all the participants to be patient with me, and then listen to this discussion, and have a great day.
Thank you
Thanks.
so much, sir, again, and find the link in the chat box for your certificate, and kindly give your feedback for us. Answer the post-assessment questions so that we can get the e-certificate, and we will send you your e-certificate for the email address within next week. So thank you so much.